The views expressed on Science for the People are not necessarily the views of this station, its affiliates, sponsors, or advertisers.
Welcome to Science for the People. Today we'll be looking at the science of illegal drugs, how they affect us, and what the best ways might be to combat their negative effects on society. Later on, Desiree Schell will be talking with Donald MacPherson on harm reduction policies, what they mean, how successful they are, and what evidence we have for that success. But first, let's take a closer look at the effect of illegal drug use on individuals and on our culture. Hello and welcome to Science for the People. I'm Rochelle Saunders. My guest is Carl Hart, an associate professor in the departments of psychology and psychiatry at Columbia University. He's also a research scientist in the Division of Substance Abuse at the New York State Psychiatric Institute, a member of the National Advisory Council on Drug Abuse, and on the board of directors of the College on Problems of Drug Dependence and the Drug Policy Alliance. He's the author of High Price, a neuroscientist's journey of self-discovery that challenges everything you know about drugs and society. Thanks for being here today, Carl.
Thank you for having me. I really love the name of this show, Science for the People.
Oh, thank you. We are really quite attached to it as well. So now lots of scientists write books, and many of them are quite lovely, but it's rare that they're as personally honest as yours is. Why did you decide to write a book about the science and policy around recreational drugs in this autobiographical format?
Well, I mean, like your show, the title is called Science for the People. And one way that you connect science with people is that you have to have a real good narrative. And for me, a really good narrative is being deeply personal and honest, because you show the sort of merits of that a person has, and you also have showed the limitation. And so the readers themselves know that they have limitations, and they know that they have these other positive attributes as well. But I think it's critically important for people to see the entire picture of a person, and so they can connect with the person. And that's what I tried to do. You know, I don't know how well I did it, but that's what I tried to do. When we think about science and the science of drug abuse, oftentimes we think about drugs in ways that are magical or incredible, like they're not connected with real people who we all know. And one of the things I tried to do with the book is to show people that the people who we study in the lab are regular folk. Not only are they regular folk, they are people just like me. In fact, they are me. They are you. They are us. And so one of the things I tried to do with the narrative was to show that, hey, I actually lived some of that life. And not only that, my community, there were people in my community living that life. And not only that, there are people in your community living that life. Maybe you too, but we are afraid to divulge such personal information about drugs because there were such heavy consequences associated with acknowledging drug use. Luckily, we have had the last 3 presidents who have acknowledged their illegal drug use when they were younger men. And so I'm hoping that other people come out of the closet as well.
Now, you came back from your time abroad with the military to a full-fledged crack panic in the United States. Can you talk a little bit about that?
Yeah, at that time, we're talking 1988. At that time, we were really concerned about crack cocaine. It was the drug that people said in the community that these young guys were making a lot of money on. Young women would be doing anything to receive a hit, including sexual favors. Mothers were abandoning their children. All of these sorts of things were being said. And many of the young guys who were said to be selling crack, of course, they were my friends because we were, at the time, I was 20, 21, and those were many of the young guys selling crack. And they tell me, oh, yeah, man, you can make all kinds of money selling crack. And they tell me these stories about how much money they would be making. And then they go home to their mother's home. They weren't making that kind of money, or otherwise they would have their own places. Then they didn't have a car. It was just kids on the corner, maybe selling the little drugs, but certainly not making a lot of money. But I wasn't critical enough to really question it then. And that kind of led me to, when I was finishing up my degree at the University of North Carolina, Wilmington, to want to study drug addiction, because here it was, this compound, crack cocaine, causing all of this bad behavior, whether it occurred in my sort of friends or my peer group or other folks, but we saw all of this bad behavior being attributed to crack cocaine. Our movies, our art, all of these sorts of things were saying that crack was the most addictive drug. And so I was going to try and figure it out from a neurobiological perspective, and that's what I set out to do.
Now, this I found really fascinating. I think we usually tend to think of the crack panic as something that white people thought about black neighborhoods, but it seems from your book that there was just as much concern about crack coming from within these neighborhoods.
Yeah, that's one of the things. It's like black folks and white folks in this country and other folks, we tend to believe a lot of the same things. We get the same crappy media, the same sort of crappy education. We're all in this thing together. So if white folks were believing, you better believe black folks were believing as well. And so they attributed many of these problems, like me, to crack, despite the fact that so crack didn't hit the streets until about late 1984. The first reports were about December 1984, but it really didn't take off until about the summer of 86 or so. And so people said that crack was responsible for high unemployment rates. The highest unemployment rates in the United States was 1982, long before crack ever hit the street. And people also blame crack for crime, all of these sorts of things. And when you look at the FBI statistics, for example, the vast majority of prisoners were not addicted or intoxicated during the time of their crime. There are all kinds of evidence that just flies in the face of this notion, but we didn't critically evaluate it because it was a nice story and it was convenient, and it's a complicated problem, particularly when you start thinking about people who don't have jobs and the high rates of poverty. Man, those are issues you don't really want to deal with. So if you can blame something like crack, then everybody's kind of emotionally satisfied in believing that they have an answer. And then if you have crack as the answer, all you have to do now is put more police on the streets and get rid of crack. And as we see, crack is no longer a big deal today, and you still have unemployment rate problems, you still have poverty, you still have crime, you still have all of these kinds of things. But I will say that one of the things that happened with crack, which was very real, is that you had new drug markets, a new sort of product hits the streets, and people are going to fight over the turfs or the market to see who controls the market. That's not unique to crack. That happens with all illicit markets, and even new markets that are not illicit, you still get some sort of activity jostling for a position. But once the markets are settled down and control is established, you don't see this kind of violence. This happened in the late 1970s, early 1980s with powder cocaine. But with powder cocaine, we tended to tolerate it and we didn't get as crazy as we did with crack, where we passed all of these harsh, draconian legislation that we now find abhorrent.
This is Science for the People, and I'm talking with Carl Hart, author of High Price, a neuroscientist's journey of self-discovery that challenges everything you know about drugs and society. So let's talk a little bit about crack cocaine versus powdered cocaine, because I think there is still, to this day, a lot of confusion between the two, even though I think this has been talked about a lot. So is there a difference? What is the difference? Is one more addictive than the other? What's going on here?
So if we think about crack cocaine and powder cocaine, the thing that your listeners need to understand is that the pharmacological effects of cocaine, whether it's crack or powder, is determined by cocaine base. Both of these compounds has cocaine base, and that's where the pharmacological action is, only in the cocaine base. But powder cocaine has an additional chemical attached to it, the hydrochloride portion, which is a salt, and it has no biological or pharmacological activity. It's there just to make the compound stable. That means that you can't smoke it. If you want to smoke it, you have to remove the hydrochloride portion from the base. And that's what people do with crack. They just simply, with baking soda, water, and a little heat, you can remove the salt, the hydrochloride portion away from the base. Now you can smoke it. So there is no pharmacological difference between crack and powder cocaine. What people respond to is route of administration. The onset of effects when you smoke a drug is more rapid than when you snort a drug. And so that means that the effects will be more intense after smoking crack cocaine than snorting powder cocaine. But if you inject powder cocaine dissolved in water intravenously, you get the same intensity of effects as smoking crack cocaine. They are the same drug.
So why then is the perception of crack cocaine, or was specifically the perception of crack cocaine, as the new worst thing ever?
Simply put, marketing. We told the American public that it was associated with this undesired group, primarily black people in urban areas in the United States. We flashed on our news programs pictures over and over of some black urban person misbehaving and attributing this to crack cocaine. We saw it in our movies. We saw it in news programs. We saw it throughout the culture. And so that's why crack cocaine has this awful image. This awful image is based largely on pairing it with bad behavior in our media sort of outlets. That's it.
So can you tell us a little bit about your early research? Some of the first things you investigated was what dopamine does.
Yeah, so my early research, I was really interested in understanding cells in a region of the brain called the nucleus accumbens and the ventral tegmental area. The ventral tegmental area projects to the nucleus accumbens, and it's a major region where dopamine cells are produced. Dopamine was thought to be involved in reward. That is, increasing amounts of dopamine was thought to translate into some sort of pleasurable feeling. Of course, this is an oversimplification, but this is how it was viewed at some level, certainly in the late 1980s, early 1990s, and some people still view it that way. But and so I wanted to figure out what would happen to these cells after morphine, after nicotine. That's what I was interested in early on. We already knew that cocaine, for example, blocked the reuptake of dopamine. So when a neurotransmitter is released, its actions has to be terminated relatively quickly in order for the brain and the person to function normally. Neurotransmitters' actions are terminated, at least dopamine and other monoamine neurotransmission are terminated primarily through reuptake and metabolism by monoamine oxidase or catecholamine transferase. Now, we knew that cocaine blocked the reuptake of dopamine, and many people thought that this was critically important for cocaine's rewarding-like effects. There had been some studies that suggested, these studies were in vitro in sort of slice preparation, had suggested that nicotine produced a similar sort of blockade of uptake as cocaine. So this is kind of radical and revolutionary. People say, oh, wow, nicotine produced identical effects as cocaine. That's probably why the compound is so addictive. So I did some studies looking at what nicotine did to the dopamine transporter in a live animal, not a slice, but in a live preparation, an animal anesthetized initially. And what we found is that nicotine produced the opposite effects of cocaine. It actually facilitated the reuptake of dopamine and not blocked like cocaine. And so I was really excited about that because that was going against what some folks the story that some people were trying to build. And it was the first time that we found that. So that was my earliest research.
What was the response to this research?
I guess the response was the same response that people get when they produce data that's not in line with the current sort of story or the major theory. It's ignored. So that's what happened.
Oh. So I also want to talk about how hard it is to get mice to push levers, because I had no idea. There's a number of studies with mice and cocaine and lever pushing. So can you walk us through a little bit of that?
So one of the things that we try to do, well, when we think about studying drug addiction or drug reward in laboratory animals, mice, rats, non-human primates, they all serve as subjects. And the thing is that we try to get them to self-administer these drugs so we can do these various manipulations to see how hard they will work to take cocaine or methamphetamine. And we like to see that these animals will take the same drugs as humans take. And so one of my early sort of studies was trying to get rats to self-administer nicotine. And I found it nearly impossible. And most people find it nearly impossible to get rats to self-administer nicotine. But some people are successful, but very few. Whereas a drug like cocaine, it's easier to get an animal to self-administer, but it's still not the easiest thing that you can do. When you get an animal to self-administer a drug like cocaine or nicotine, you have to, for example, food deprive the animal, make sure there's nothing else available to the animal, so the animal only focuses on administering that drug. If there are other activities, it becomes really difficult for an animal to self-administer a drug or to learn to self-administer the drug.
This I found really fascinating because I think most people have heard about the cocaine rat lever story, but I don't think a lot of people have heard really the most important part of that story, the other half of it, which is, a lot of the rats who are willing to push the levers have to be severely isolated and are not living as a normal rat is wont to live. But if you put a rat, it seems, in an interesting environment, it's really hard to get them to go for that cocaine.
Yeah. Many of the studies done in laboratory rats, the animals are not living in their sort of like natural habitat or the way that they normally live. They're isolated. Rats are like humans. They're social animals. And when you have them in a social setting, it's really difficult to get these animals to self-administer cocaine or these other drugs. And, you have things available like a sweet treat, like sweet water, sugar water, or a sexually receptive mate. It becomes almost impossible to get an animal to learn to self-administer something like cocaine. That speaks to this issue of, there are multiple issues here. One of the things is that we have seen those studies where some researchers present data where animals will self-administer these drugs until they die. But they never tell the audience that they isolated these animals completely, and the only option that the animal had was the lever leading to cocaine self-administration. And they never tell people that when you provide alternatives, even when you've taught the animal how to self-administer a drug like cocaine, the animal will not take the cocaine until death. Just like humans, if the animals have alternatives, other things to do, other attractive options, the animals don't choose to take the drug.
This, I feel, really goes against the idea that drugs like crack cocaine, if you get the story of you take one hit, you're done. You're addicted for life. You can't ever go down that rabbit hole. And this research tends, to me anyway, suggests that maybe that's not the case.
Well, if anybody's telling anybody that you take one hit of anything, you're addicted, the person who's listening now has a license to stop listening, because the person who's talking thinks that the person who is listening is an idiot, or they themselves are an idiot, because there is nothing that you take one time and you become addicted. Addiction, by definition, requires work.
This sounds oddly familiar. I'm thinking now of the meth scare that has happened in the last 10 years. I'm assuming there are some parallels here.
Oh, absolutely. As you may know, in the book, there's chapter 15, I think it's called The New Crack, where I'm talking about methamphetamine. These humans, the beautiful thing about humans is that we evolved so slowly. So that means that we only have a limited sort of behavioral repertoire. And when we think about what we've said about drugs, the dangers of drugs, in the early 1900s, compared to what we're saying about the dangers of drugs today, they're the same arguments. They are the same nonsense, oftentimes. And so when you think about methamphetamine today, people have said, it's the most dangerous drug that we've ever experienced. Oh, we heard that story before with crack cocaine. One hit and you're addicted. We heard that story before with crack cocaine. Oh, no, but you haven't heard this story. Methamphetamine causes you to become unattractive and lose your teeth. So you hear all of these stories and you say, all right, well, let's evaluate that one. Let's think about it. Methamphetamine is the same drug as amphetamine, D-amphetamine. Amphetamine is the major ingredient in a drug called Adderall. Adderall in the United States is the number one drug prescribed for attention deficit disorder. A number of people are taking it. And people take it every day. No one's talking about meth or Adderall mouth with people who are taking Adderall and amphetamine mouth. They're the same drug. They produce the same amount of vasoconstriction in the mouth. I mean, vasoconstriction can cause the mouth to be dry, of course, and those sorts of things. And when you have a extreme dry mouth syndrome, that might lead to some bad sort of dental work or bad dental. It may look as if your teeth are not as healthy, but that would have to be extreme. We get drugs like antidepressant medication. All of those medications, they all produce some vasoconstriction in the mouth and cause some dry mouth. But we don't talk about those drugs as causing people to become unattractive and lose their teeth. Again, when we think about these things that have been said about drugs, like methamphetamine, they are largely exaggerations. And this is not to encourage people to go out and use illegal drugs, because the use of illegal drugs can be dangerous for a variety of reasons, but oftentimes not what people are saying that they're dangerous for.
And we'll be back after these messages with more of Carl Hart, author of High Price on Science for the People.
Science for the People is a weekly radio show exploring everyday life from a scientific perspective. To find out where Science for the People airs near you, or to listen to past episodes, check out our website at scienceforthepeople.ca. You'll also find links to connect with us on Facebook, Twitter, and Google+, or to subscribe to the podcast in iTunes. And now, back to the show.
Welcome back to Science for the People. I'm Rochelle Saunders, and I'm joined by Carl Hart. He's the author of High Price, a neuroscientist journey of self-discovery that challenges everything you know about drugs and society. So you have done some more addictions research since then, and some of it actually involves giving regular users illegal drugs. That must have been so much fun to get through an ethics board.
It really isn't as difficult as people think. The bottom line is this. We live here in Western civilization, we live in fairly wealthy societies. And wealthy societies should base their education policies and all of those things on the best available information and evidence. There are a number of things we don't know about these drugs, and one way one way you acquire knowledge is to conduct science. And so we've made a lot of policies for these drugs based on little evidence. And what we're doing in our research and other people is we're collecting the evidence that will help to inform not only policy, not only education, but also treatment. And so when you make a compelling case that this information, this science will help inform all of those domains, it's not so difficult to get approval to do this work as long as you have the proper safeguards and experience in place. And we certainly do. We've been doing this kind of work for more than 20 years now.
And of course, as we are often fond of reminding people on the show, because I think it can't be said enough, there's really only so far we can go with animal trials.
Yeah, I think that the animal work and the human work can be complementary. And I think that the animal studies, they raise some really important questions. And sometimes you have to take those questions into humans. And otherwise, if you're basing what you're doing solely on animal studies, in many cases or some cases, that might be considered irresponsible.
So can you walk us through some of the drug research you've done with humans on these drugs and give us a little bit more information about some of the questions you were asking and what you've found out?
An interesting study that we did early on was based on these animal work. So like I said, that the animal studies can raise some really important questions. The rat in the cage left alone and has an intravenous catheter hooked up to a lever that they press for a cocaine self-administration. That was fascinating work, but we discovered that when you provide the animal with alternatives, they don't take the drug as much. Question becomes, do humans behave the same way? If you bring crack cocaine addicts into the lab, and when I use the term addict, I'm referring to the DSM term, substance use disorder. You bring these folks into the lab, offer them $5 or some alternative, and a hit of cocaine worth more than $5. What will happen? If you repeat this multiple times over several days, what will happen? Well, what we found is that a nominal amount of money, as low as $5, could decrease choice to take crack cocaine in people who are identified as crack addicts. Pretty amazing when people have had the notion or the belief that, a crack cocaine a crack cocaine addict can only respond to another hit of crack. They will never say no if the dose is nice and it's a good hit. It's not true. If you provide alternatives, we've repeated that study with methamphetamine users. They behave just like the crack cocaine users. They took drug on about half of the occasion and money on the other half of the occasion. But when you increase the amount of money to something like $20, they almost never take the drug. They always take the money. And so all of these kind of questions become critically important because it tells us that it provides a clue about treatment. It provides a clue about the nature of the people who are using these drugs, because you say, well, they're responding rationally, just like you would expect. Not only are they responding rationally, but maybe we can develop some treatments that have this as its sort of guiding principle. If we provide alternatives, maybe that will be useful in treating drug addiction. All of these sorts of things have led to various types of treatments.
Your book is really an interesting commentary on what the definition of drug abuse, I think, should really be, because we often think of the term drug abuse as being a technical term about a drug's effect on somebody, whereas I feel after reading your book, it's a little bit more about society's effect on someone choosing to take a drug.
Well, I don't know exactly what you're responding to, because when I think of drug addiction, the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, and also the ICD-10, the International Classification of Disorder, they lay it out clearly what addiction is. It is someone who is endorsing or meeting a certain number of symptoms. Symptoms like people repeatedly engage in the behavior of taking drugs despite knowledge of some psychiatric or physical illness that is exacerbated or worsened by taking the drug. They spend more time than expected or use more than an amount of drug than they initially intended to. They have given up important occupational, educational, or social obligations for the drug. They repeatedly put themselves in harm's way, like while intoxicated on the drugs, like driving under the influence. there are a number of symptoms that people have to meet to be identified as drug addiction, as addicted to a drug. So it's kind of clear. That's easy and simple and clear. But when we think about the impact of society on the drug user, oh, that's a whole different can of worms, because our response to drug use in our countries, in the United States, in Canada, has it actually, in many cases, is worse than the drug itself.
That's what I find really interesting. And thank you for the DSM definition, because I don't think enough people know what the actual DSM definition of drug addiction is. We really think of drug addiction, I think, from the standpoint of the average person on the street, as being a person who takes drugs.
If that's the case, I'm a drug addict.
So there really is a case here for recreational drug use versus addictive drug use, and that one really is possible without necessarily leading to the other.
Yeah, of course there's a case for recreational drug use. And, this is partly why I wrote the book, because the conversation surrounding drugs is so low level that it's frustrating for anyone who thinks, of course, people can use drugs safely. And not only that, but this is not news to people who use drugs, by the way. I apologize for people who are out there and they use drugs. I'm sorry. I'm speaking to the folks who don't. We all know that drug use can enhance human functioning. That's why we go to our physicians and get drugs like amphetamines. That's why we get drugs like opiates. That's why we get a number of other drugs to enhance human functioning in some domain. That's why people drink alcohol at many of the boring science parties that we have to attend, to enhance human functioning. Because these parties in some cases, and people in some cases, are a bit difficult to tolerate. Drink a little alcohol, decreases anxiety, makes people a little more interesting. You get through the evening. Enhancing human functioning. We all know these things, but we are just not honest about these things.
So it seems like, to me, a lot of which drugs we decide to demonize and which drugs we don't, because as you said, nicotine is technically a drug, alcohol has a drug-like effect, whether or not we call it a drug, is more about who's taking it and what types of stories are being told.
Yeah, I mean, as a psychopharmacologist, I don't say like nicotine is technically a drug or alcohol has drug-like effect. They are drugs. In fact, alcohol is probably the ideal drug. It's a small molecular sort of compound. I think it weighs something. It's so light compared to something like cocaine or heroin. It's ideal for getting into the central nervous system, interacting with receptors and altering behavior. It's one of the reasons that it's our social drug. You only need alcohol is one of the few drugs that you can take orally, and it gets into the central nervous system, the brain, really rapidly. There is essentially no blood-brain barrier for alcohol, unlike these other drugs like heroin, cocaine. And so what's in the blood, whatever levels of alcohol is in the blood is in the brain. That's why we can look at someone's blood alcohol concentration to try to determine their level of intoxication. You can't do that with any other drug. And so alcohol is the ideal drug. And if people are thinking about alcohol in any other way, they are naive or uninformed. And certainly alcohol can be as toxic as those other drugs, and more so in many cases. All of the drugs that we're talking about, heroin, cocaine, methamphetamine, none of those drugs you can die from a withdrawal syndrome, but you can die from an alcohol withdrawal syndrome. So alcohol is clearly a drug, and it is an important drug in our society.
So I'm assuming that you are an advocate for evidence-based drug policy then.
I'm an advocate for evidence-based anything.
I like you. I am on your side, sir.
Right.
So what are you finding for you? Because in your book, you talk a little bit about the struggles of trying to get some of this research information across to the people who can actually use it to make real change. So what are the barriers you're coming up against here? I'm assuming it's not necessarily from the science community.
No, the science community actually they've been a barrier. I mean, I know that's one of the things that I'm like you. I initially started out like thinking that, oh yeah, I know the scientists will get it. But so we can talk about the barriers. This will be a little longer conversation because we'll start with the scientists as a barrier. When we think about the area of drug abuse research, the number one funder in this area is the National Institute on Drug Abuse. I wrote an op-ed in the Dallas Morning Star about 2 weeks ago on this. The number one funder is the National Institute on Drug Abuse. They fund 90% of the world's research in this area. Their mission is narrowly defined to focus on the bad things that happen after drugs or as a result of these drugs. That means that scientists are disproportionately looking for bad effects of drugs. Most of the people who use these drugs don't experience these bad effects. Only about 10 to 20% of the people who use these drugs might meet criteria for addiction. The vast majority, 80 to 90%, don't meet criteria and don't experience these bad things after taking these drugs. But almost all of our science and almost all of our sort of information is focused on the bad things. So even the scientists in this area are misled or their perspective is biased based on the sort of mission of their main funder. And so that's a concern. And not all scientists, but your audience should be aware that even the information that you get out of science in this area is skewed toward pathology. That's one sort of one of the walls that you bump up against. And of course, you bump up against law enforcement, who is deeply invested in making sure that we keep these things, we continue to regulate these things in the way we have, because we spend in the United States $26 billion a year fighting the drug war, as they call it, the control of drugs, and 70% of that money goes to law enforcement. And so if we talk about changing the way we do any of this, I don't know what changes we want to make, but any changes might cause law enforcement to lose some of their money. 50% of the prisoners in federal prisons are there for drugs, and about a quarter in the state jails are there for drugs. And so if you start to alter anything about regulating drugs, all of those people stand to lose money. And politicians will no longer be able to simply say, drugs are bad, we're going to put more cops on the street, I'm going to do something about it. They can no longer say that. They may have to say, oh, we may have to educate people how to stay safe. We might need to take a more nuanced approach. We might need to actually know what the evidence is. And so a number of people stand to lose. And so as we think about changing how we educate and our policies and how we treat folks, we have to also consider the vested interests of all of these different constituencies.
That sounds almost depressingly complicated. But I hope things improve. Do you have any kind of last takeaway for people from your book? If they could only take away one thing from your book or from this conversation, what would you like that to be?
The major thing that I hope people take away from the book, from the conversation, is that they have been misled about drugs and what drugs do and don't do. People should understand that as a scientist, I have given thousands of doses of these drugs to folks. And one of the most important lessons I have learned is that drug effects are predictable. As you increase the dose, you increase the likelihood of having toxic effects. But as a result, we know how to keep people safe. We just need to share the information with people, and we have not been forthright in doing so. And this is not to encourage people to go out and use illegal drugs. You already know better than that. This is to say that we have exaggerated the extent of harm associated with these drugs. If we're more honest, we could have a better approach that will help more members of our society.
Carl, thank you so much for being here. It is a fascinating book and a really interesting, relevant topic.
Thank you for having me. I really love the title of this program, Science for the People. That's what I hope I help to disseminate, science for the people.
And we've linked to Carl Hart and his book, High Price, on our website at scienceforthepeople.ca. After the break, Desiree Schell will be back with Donald MacPherson, Director of the Canadian Drug Policy Coalition, to talk about harm reduction drug policies. Stay tuned.
Science for the People is a weekly radio show exploring everyday life from a scientific perspective. To find out where Science for the People airs near you, or to listen to past episodes, check out our website at scienceforthepeople.ca. You'll also find links to connect with us on Facebook, Twitter, and Google+, or to subscribe to the podcast in iTunes. And now, back to the show.
Welcome back to Science for the People. I'm Desiree Schell, and with me is Donald MacPherson, Director of the Canadian Drug Policy Coalition, which is a national coalition of organizations working to improve Canada's drug policies. He's the author of Vancouver's groundbreaking 4 Pillars drug strategy, which calls for drug policies based on public health principles and appropriate regulation of psychoactive substances. Donald, welcome to the show.
It's a pleasure to be here.
Now, the term harm reduction isn't necessarily one that everyone is familiar with, so let's start by defining that. What is it exactly?
It's an interesting concept that really entered the lexicon around issues of substance use post HIV, when the primary philosophy of dealing with people with substance use problems was to help them stop using. Post HIV, there was another prerogative that really became, or imperative, I guess, was that what's more important, to prevent HIV or to address someone's substance use? And clearly, if you're looking at an effective expenditure of public resources, scarce public dollars, you have to come down the side of preventing HIV as your primary objective. That's when the whole notion of harm reduction started to enter the lexicon of responding to substance use problems. And it really is about trying to prevent deadly infectious diseases as your primary objective, and meeting people where they're at, addressing their substance use problems. Maybe not, maybe so, but that's not your primary objective. And that, in a way, that has made harm reduction quite a contentious issue in our society anyways. So it's a philosophy that tries to engage people, as many high-risk people as possible, work with them to move towards better health.
So if harm reduction strategies do aim to reduce risk among drug users, what are the major types of risks that drug users face?
Drug users face a wide range of risks. Catching people who inject drugs are susceptible to a range of bloodborne infections, including HIV, hepatitis C, and other infections. Overdose death is a serious problem globally when it comes to people who use opioids and stimulants, but primarily opioids. Marginalization from mainstream society because of the stigma of being a drug user. The notion of trying to maintain oneself on a substance such as methadone, which came into the array of treatment options, was something that an advancement in harm reduction in terms of not requiring people to stop using an opioid, but having an opioid as a medicine to treat a heroin addiction. So, a wide range of fairly serious, deadly consequences, including marginalization from health services and other aspects of society. Harm reduction attempts to address those and bring people back into engagement with the healthcare system and with community, with families, etc.
Well, of course, if it was all risk, then no one would ever do drugs, but that is not the case. We never hear people talking about the benefits of drug use as perceived by the people who use those drugs.
That's right. Most people use drugs for a perceived risk. A perceived benefit, sorry. People don't use drugs because they want to take serious risks with their health or with their lives. There's a perceived benefit that drives people to use substances, and most people who use substances don't develop problems with substances. That's sort of known globally. Most people who try drugs don't develop serious dependencies on them or serious problems with them. If that were the case, then we'd have a much bigger problem than we have now. And because of the criminalization of drugs, globally, punitive approaches we've had, we rarely get to broach the issue of beneficial uses of drugs. You're beginning to see it more with cannabis now because of the medical qualities. With opioids, it's clearly in the downtown east side of Vancouver and other major cities in Canada, people are self-medicating. Sometimes medication from illegal drugs works better than the medication from psychiatrists. So it's a really complex, risk-benefit discussion that we need to have in order to move forward and develop sound policies around responses to drugs.
Can you give us some examples of specific harm reduction strategies? What are we using?
I always start this discussion with, harm reduction is about relationships. It's about building relationships and deepening those relationships with usually a fairly marginalized person or group of people. And then figuring out what is the best way for that person to reduce harm of their substance use. And harm reduction acknowledges that the person who's using is the best advocate for their own reduction in harm. They need to, be heavily involved in these strategies. So it might be shifting, helping a person who lives on the street or in a back alley shift towards better housing, shift towards attending syringe exchange programs, engaging, if they're an opioid user, trying to get on a methadone program. In Vancouver, the police have recently encouraged people to use Insight because there's some very strong street heroin out there. So it's a range of interventions, but it's also a philosophy of working with people.
This is Science for the People, and my guest is Donald MacPherson, Director of the Canadian Drug Policy Coalition. Well, let's use Canada as a case study for a minute. What is our current drug strategy?
Well, our current drug strategy changed when the Conservative government came in 2005. We used to have a national drug strategy that involved 4 pillars of harm reduction, treatment, prevention, and law enforcement. And it was an attempt to look at the social determinants of health and begin to respond to individuals, communities, municipalities, regions with more of a comprehensive approach to substance use in Canada. When the government changed in 2005, they shifted the emphasis to an anti-drug strategy. So in doing so, they put the drug at the heart of the strategy. And this is one of the problems with the whole area of drug policy. If drugs are the problem, then you have a very narrow array of options to proceed with, because your focus is on the drugs as opposed to on the society, on the individuals who are using substances, on all of the other factors that lead to problem drug use. The drugs are really, in my opinion, neither here nor there. If you remember years ago in Davis Inlet, there were people, the CBC crew went up there, found a whole bunch of young Inuit people huffing gasoline out of brown paper bags. And these images flashed across Canada, and it was absolutely heartbreaking to see these 11-year-old kids out behind their houses huffing gasoline. And when we saw those images, Canadians, not for 1 second did people think gasoline was the problem. We all understood that it was all sorts of other complex problems. It was residential schools. It was intergenerational drug, dependencies. It was shattered families. It was a shattered economy. It was colonization. It was all of those things. No one thought gasoline was the problem. Had it been methamphetamine or marijuana or cocaine, we would have focused on the drug as a problem, and we would have said, let's get that drug out of there. That's what's causing the problem. So right from the get-go, we have the locus of our solution thinking and framing in the wrong place. And that's what drug prohibition is about. It's about pretending that the drug is the problem as opposed to all the other aspects of society that impinge on people that leads to problematic drug use.
Our current drug strategy is basically focused on enforcement more than anything else at this point.
Primarily, it's an anti-drug strategy, and it's about enforcement. It's about border control. It's about punishing people who use illegal drugs.
Well, people still see this argument, enforcement versus harm reduction as somewhat ideological. So let's bring in some evidence, if we could. How is the drug strategy working that we currently have, and how do we know?
Well, that's a good question. We don't know. There hasn't been a good evaluation. Drug prohibition hasn't been evaluated. And jurisdictions refuse to do that because, so what do? We have to find the evidence, in terms of harms. So we have mass incarceration in the U.S. We have, punitive approaches growing in Canada. We have HIV epidemics. We have overdose epidemics. We have lots of sort of negative evidence emanating that we can tie back to that approach. But we also know that drugs are more available now than they were 40 years ago when Richard Nixon declared the war on drugs. Purity is higher, price is lower. That's the kind of evidence we have about the current approach. Around some harm reduction initiatives, we can look at the UK in terms of syringe exchange. They were very quick in the late 80s to get out of the gate and distribute syringe exchanges all over Britain, like hundreds and hundreds of needle exchanges. And they never had an HIV epidemic like we saw here in Vancouver or Montreal or New York. The Australians did a good job as well around syringe exchange, and they prevented their HIV rates from climbing, and to some extent their hepatitis C rates are lower than ours among drug users. So there's good evidence that there's compelling evidence that needle exchange works, that opioid substitution therapies work. Harm reduction is good value for money. The cost per HIV case averted is estimated to be between $100 and $1,000. So that's a really cheap way to avert an infection or a disease that can cost between $250,000 and $500,000 over someone's lifetime. And we know that the evidence, again, growing out of the HIV science, we know that laws and policies that undermine access to harm reduction are key drivers of HIV and hepatitis C. So we know a lot about the negative impact of our current policies, and there's sort of this willful denial of evidence is absolutely it's criminal that we have programs that work. We know they work. They're not scaled up. They're not available widely. Coverage for harm reduction programs is better in Canada than it is in the U.S., but it's not anywhere near what it needs to be.
You're listening to Science for the People, and I'm here with Donald MacPherson, Director of the Canadian Drug Policy Coalition. So even with all of those studies and all that evidence, Canada's federal government seems what can only be described as hostile to the idea of harm reduction, does it not?
Absolutely. It's almost as if the Prime Minister it's one of the pillars of planks of his strategy is to oppose harm reduction. And here's a quote from him on his maternal health initiative that he is getting so much kudos for around the world. I frankly don't understand people who are walking away in our society from something that's proven to work. Harper then offered his advice to those who go off on their own theories and not listen to the scientific evidence. Don't indulge your theories. Think of your children and listen to the experts, he said. He could be talking about Vancouver's supervised injection site, which he has tried to close since he became elected. So that is that's a willful denial of evidence that, or the cherry picking up evidence. I'm going to use the evidence around maternal health and tell the whole world they should follow the evidence. But when I have this evidence around something I don't believe in, like harm reduction, I'm going to willfully deny that evidence exists, or that it's not good evidence, or the people who created the evidence did it poorly or badly. So it really is that's why I say it's criminal. It's an abuse of power. It's ignorance in terms of having an evidence-based drug strategy, and it should not be acceptable to Canadians.
Well, what's their rationale for their opposition?
I've asked several people who have been close to the Prime Minister's office, and they don't know. They just say, well, I think they just don't like it. So that's sort of, he frankly doesn't understand people who act that way when it comes to maternal health. Well, I frankly don't understand his position when it comes to saving lives of marginalized people who use substances and need all the help they can get.
Well, do you think the biggest problem is that harm reduction is largely misunderstood by the public?
Yes, I think most people would like people who are using drugs in a problematic fashion to stop. And the fact that harm reduction doesn't necessarily start with that notion is problematic for people. The irony is, if the evidence we see from Insight, the supervised injection site, is that if you use Insight, you are more likely to go to drug treatment than if you don't use Insight. So harm reduction has a role to play as that low threshold, open door place for people to get into the healthcare system and to even begin to contemplate reducing or stopping using a substance that they've been using for some time. And that's what people don't understand, that it's not either or. It's not either abstinence programs or harm reduction programs. Harm reduction is just a key component to a comprehensive system that will give people opportunities to get stronger, get healthier, and then maybe reduce or cease their substance use.
Donald, thanks very much for being here.
Okay, great. It was a pleasure.
If you want to learn more about Donald MacPherson or the Canadian Drug Policy Coalition, you can visit drugpolicy.ca, a link you'll find posted on our website at scienceforthepeople.ca. Science for the People is recorded in Edmonton, Alberta. The show is produced by Rochelle Saunders. Ryan Bromsgrove is our promotions manager. Our social media manager is Chelsea Butler. K.O. Myers updates our website. Helen Quivalon is our publishing liaison. Ed Haynes is our guest coordinator. We get research help from Josh Witten. The show is edited by K.O. Myers and Ryan Bromsgrove. Our theme song was written and recorded by Fractal Pattern, and its title is Binary Consequence. The show is hosted by Rochelle Saunders, Marie Claire Shanahan, and me, Desiree Schell.